Our scene today is that we have a 70-year-old male who has onset of chest pain and feeling dizzy. On arrival, he's been sitting in his lazy boy and we've done our first initial ABC assessment. His airway is clear and patent. He is breathing adequately. He does not have any radial pulses, but he does have a strong carotid pulse, and he's feeling cold and clammy at this stage. I've asked my offsider to get me a full set of vitals, and he has a heart rate of 170, a blood pressure of 70/40, rest rate of 18, a BGL of 7.6, and a temperature of 37 degrees. Our patient does have a past history of an MI. However, we do know that this chest pain has been different to the last time he did have it. We have done a 3-lead, and on the screen we have shown that it is VT. So we're just going to print that strip out and try and determine any differentials. So determined between VT and SVT. Our patient doesn't have any history of any renal issues. He's not on dialysis. He has eaten today, so that kind of rules out the metabolic or electrolyte imbalances. Our patient cannot obey any commands, and with his blood pressure being 70/40, he is very hypotensive. And because he is also elderly, this puts it more into the range of VT rather than SVT with aberrancy. It is also a wide complex tachycardia rather than a narrow complex tachycardia. So I'm convinced that this is VT. He is severely compromised, so I would have asked my offsider to call for an R50 backup for a status 1. In the meantime, I'm going to prepare to cardiovert this patient. So what I'm going to do now is prepare my resus gear. So I'm going to get my BVM out, set that to the side, and I'm now going to attach my defib pads. And now I'm going to consult my cardioversion checklist. We've also put an IV in this patient in case we need to give any other medicines or in case he does go into cardiac arrest. So preparing for cardioversion, the pads are in the apex sternum position as recommended, and we do have our 3-lead monitoring on. We're going to turn the defibrillator to manual mode, strictly maximum joules. We're going to select the lead with the highest R wave, which you can see here is lead 2, and we are going to select synchronized mode, make sure that we see those QRS detection symbols. Print that strip out to confirm. So we can see that there is a detection symbol above every QRS. So I'm happy with that. I'm happy that that's still synchronized. The patient will not need to receive any sedation at this point because he is unable to obey commands, so we do need to cardiovert. If the patient was able to obey commands, then I would be looking at sedating this patient with ketamine. So we're going to set the joules, charge the defibrillator. Defibrillator's charging. Alright, making sure that everyone's clear. Still on VT, everyone clear, shocking. Shock delivered. Alright, reassess his ABCs, making sure that his airway is still patent, he is still breathing. He does have a circular radial pulse. As you can see, has been converted back into normal sinus rhythm there. So we do not need to administer a second cardioversion. If we did, I would make sure that the sync is re-engaged on the defibrillator ready to go.